Hey, folks. I'm Elena.
I'm Darah.
And this is Where's the Adults? Podcast about being caregivers when you don't feel like you're the one to do the job.
Because we're talking about families and what to say and what not to say. What are some of your pet peeves that families say to their loved ones? One of my personal ones is when people that don't talk to my dad a lot are like, you remember me? You remember me? You remember me? You remember me?
Yes.
I'm like, please stop saying that.
So there's things that I see that sometimes families and caregivers are doing that might not be helpful, and that I try to help give people a little guidance on. But kind of quizzing your loved one or sort of testing them to try to see what they remember is not always super helpful, and just can kind of lead to more upset feelings on behalf of both parties. But so I try to tell people not to, quiz their loved one. I try to help people understand not to argue with them. Of course, that's very hard because sometimes as a caregiver, when you're frustrated or you just need somebody to kind of do something so you can get through your day, it can be really hard. And that's part of our aging brain care program with our caregiver coaches, to kind of help teach people how to do that. But yeah, trying to avoid arguing, helping people know how to distract their loved ones, especially if their loved one is kind of stuck on a topic, instead of trying to correct them, like just try to kind of navigate them away from that topic. I'm also very big on trying to change some of the language we use in clinical settings too, with people living with dementia. There are some words that we use very routinely, like in the hospital or in medicine, that I think we need to change. I think the word agitated or agitation kind of carries a really negative connotation. It's hard because that's a word that a lot of people use to describe distress, but I think there's different words we can use that don't feel so negative. When we talk about somebody that might need to transition into a higher level of care, I hate the word placement. Like that's what we do with an object, not a human.
Oh, yes. Yes. That is a good one.
I'm trying to, role model a different way to say that, and to see if we can get that word out of the vocabulary.
What should we say instead?
Transition to post-acute rehab, transition to a higher level of care, transition to a senior living community. I think language is really powerful, especially in clinical settings, and can influence the way we treat older adults and the type of respect we have for older adults and their families. I think also trying to talk to the person, the patient, and not just talking around them to their families. That's hard as a provider because sometimes we just need the information that our families can provide, but trying to keep the person at the center of the visit in some way is very important to me. I don't always do it well either. It's kind of a daily practice. Sometimes, some days I do it better than others, but I think that's something that I really try to role model for people I work with.
We encountered a doctor who talked at Lloyd in a very loud manner, and it was late. It took a lot to not want to go back at the doctor and correct what they were doing. So yeah, I feel that one a lot.
Yeah. There's also, I think, a feeling among clinicians sometimes that every older adult might have hearing loss, and many do. It is very common, but that like shouting is the way to go. Yes. No, I mean, talking slower sometimes and really making sure somebody can see your face and enunciating can be helpful, but shouting actually usually just makes things worse. But sometimes it's hard to break people of those sort of instinctual habits that they have, but it's something that we need to work on and that we are working on.
We learn to lower our voice when we talk to our dad.
Yeah, because the higher your voice is, the harder it is. So I'm like, Dad, how are you today?
And talking Lloyd.
And talking in a calm voice. Yes, people with age-related hearing loss do lose that higher frequency pitch hearing sooner. So they do better with a little bit of a lower pitched, slower voice.
Yes. People asking my dad to be a parrot. That's also one of my pet peeves. Lloyd, It's January 1st, 2016. Or 2026. Oh, maybe I did something wrong.
Maybe you're having some cognitive
I just
issues.
lost 10 years. Lloyd, what year is it? I'm like, even if he said it back to you, he's just parroting. He doesn't know. Like, what? I'm like, please stop asking him these questions.
Yes, that's
Please
another
stop.
thing. When I'm working with trainees, I do work with residents in the hospital. I try to train them on kind of the correct clinical ways to look for delirium, because I think that's what people think they're doing with those questions. But there are ways that we can assess somebody's ability to concentrate and pay attention. And sometimes it involves asking them some questions, but what day is it? Where are you? Those are not actually clinically helpful questions, and they're demeaning and they're annoying for patients and families. So I try to, the kind of what we learn in clinical settings, the orientation questions, I say, okay, let's not do that. Let's try not to do that. Let's not, how about we just engage the person in things that they might like to talk about? Like, hey, do you like football? Who did the Steelers play last weekend? And to kind of get a sense of, okay, are they, sort of oriented to dates and situation? Like, how about we just make a conversation with our patient and see if, see what kind of assess their cognitive function in that type of way, instead of quizzing them in a way that feels kind of less than the dignity that they deserve.
Yes.
I feel like a lot of the world's problems could be solved by just having a conversation.
Yeah.
Yes.
Yes. Connecting with the person, even if somebody living with pretty advanced dementia, you can still make a connection with that person.
Yeah. Oh, I feel like we really connected with our dad while he was in the hospital. There is a place where he grew up that I thought, oh, he's confused. But Elena's like, no, that's a real place. I was just like, does he think he went to the war? Like, what? I'm like, Saigon. Like, you've never been there.
Saigon. That's where he was at. And yes. But like where that memory came from. But we just rocked with it. Like, if this is, you want to keep telling me that you're going to the same place? I don't care. All right. You went there. Okay. Well, what did you do there? Well, I did this. Okay. And he just kept saying the same thing over and over, but he was chill. He was calm. It was fine.
Even in this state, we're still learning. Like, his Alzheimer's is unlocking random memories from his past that he's never shared with us before.
Yeah.
And at this point, we don't care if they're real or not.
Right. It's just, it's a connection.
Yes. And there's something about it that's important to him. So I was like, oh, like after he did it, I was like, let me get on Google Maps and, oh, that's where it was. Oh, I had no idea. Like, yeah, I think that's the part that clinicians, caregivers, the general population need to understand, that even in this advanced state, like, people can always give you something. We can always learn and experience things from everyone, that it's not like, oh, well, he's at this advanced stage, whatever. He can only do this or that. No, like, he still is.
The person is still in there.
Yes. And he's still. So our dad has always been a sweet guy.
He is.
He got a little pervy for a little bit, but
He sure did.
I think he's over that. That was a phase when he thought he was 22 at 70, but now he thinks he's
55.
Now he thinks he's 55. So he's done being
Met in the middle.
Right.
Yes, he's done being pervy, and he's still. Oh, thank you so much to everybody. Oh, thank you. Oh, you're having a baby. Oh, like, just so sweet and gentle and kind. I'm like, oh, he's back. Lloydikins is back.
Yeah.
Yeah.
I mean, did we want to be in the hospital? No.
No.
But it was very special for us to spend that time with him when he was in a more recognizable state to us. Where, like, he was our dad. He wasn't Lloyd then.
Yes. Yeah, he definitely was our dad in the hospital. Yeah, definitely. And something about being in the hospital and spending that much time with us, he knew who we were. He knew our names.
Yeah.
He
used our names.
It's all so mysterious, though, isn't it?
It is.
Yeah.
It is.
As much as that was hard, and I would not, of course, have wished for him to be in the hospital. I'm glad that you kind of got to share that experience with him and with each other too.
Yeah. Yeah. I think that's the message I would tell you to tell caregivers, to enjoy the blessing in whatever the situation is. So even in like the bad situations, like it's still, you know, I had to change my dad one time at your office. That was not fun. Nobody wants to change their dad, especially in public. But the fact that he was like calm and knew that I was like a safe person and that I could do it, like even in that trauma, there still was, he still knows I love him and he still loves me. And that's why he's letting me do that. And this is why he is,
Yeah, I'll give you that.
Yeah, sometimes you have to search for it. You know, sometimes it's not blaring in your face. It's not like, oh, this is the good part.
Right. I think finding some good in every bad situation is just also survival.
What kind of advice would you give to caregivers, especially if people are like new to this journey? Yeah, we'll do. What would you give to new caregivers, and what would you do to seasoned caregivers that are like, I can't do this?
I think for new caregivers, I think finding a way to educate yourself as much as possible and getting connected to those resources so you don't have to do that alone. One thing with our different programs that has been really interesting is to see how our program is most helpful for people that are really new in the journey, for people that are kind of in the thick of the journey, and then for people that are so stressed that they're kind of like about to go over the edge of the cliff. Like sometimes actually our program, like our aging brain care program, helping people out in the community, sometimes our program actually can't help those people because they cannot handle even one more phone call. They are just
Too far gone.
so maxed out. So like we really want to get to people before that. Sometimes in the very beginning of the caregiving journey, the person is still sort of doing okay, but I still think that's a really good opportunity to get educated and to kind of, I mean, nobody wants to live in kind of these worst case scenario mentalities, but I think to prepare for what might be ahead, to get things organized. So as far as financial, legal, get things organized really early, because that's not something you want to be trying to do kind of in the midst of a health crisis. There's a lot of accessing good dementia care really depends on finances, unfortunately. So having an understanding of, you know, whoever the loved one that you're taking care of, what's going on financially, where's the paperwork, where are the documents, how can I access, getting power of attorney in order is super important to do that early, especially if we're talking about dementia, while the person is still able to really kind of weigh in on all those decisions. For people that are kind of farther along in the journey, definitely taking care of themselves, taking some time off, and whatever resources can help you do that, building that village.
I think like that's what we talked about on our episode with Melanie. While you can, or when you can, talk about that. You know, get those things in order. What do you want? How do you want to, if something happens, how do you want to live out, you know, the rest of your life? Like our dad was very clear, even in his current state, I do not want surgery. He told them very clearly, but we already knew.
Yeah.
So we could advocate for that.
Yes.
He told us what he wanted before.
Yeah.
And yeah, like that was a blessing that we know, like he doesn't want a feeding tube. He doesn't want surgery. Like,
Because it makes it easier, because then you don't have to be the one to make that decision of, am I doing the right thing? Would they, you know,
you always want to think about what that person would say in every situation.
Yes.
Not even what they would do, but like, what would they say? Like if they were sitting in the chair that you're sitting in, kind of watching everything unfold, what would they say?
Yeah. Well, that's good. That is a good way to look at it. But I think people don't have these conversations.
It can be an uncomfortable conversation. And also it depends a lot about like just the kind of family you're in, kind of like in your whole life. You know, have you been in a family where you can talk about uncomfortable things? Some families have a really hard time forever. Yeah. You know, talking about uncomfortable things, or some families have really difficult and uncomfortable relationships. So there's a lot of unfinished business, a lot of guilt. All of those things play a role in somebody's ability to kind of make these decisions. And it can be really hard. And for me as a provider, I try to see if I can sort of dig a little and pick up on some of that without being too invasive. But, so of course it's easier when I have time to get to know a family. But if I'm working in the hospital or just meeting somebody, I try to pick up on some of those cues, or at least create a safe space if people want to talk about some of those things that might be making it really hard. Sometimes I can pick up that there are relationship dynamics that are making it very difficult for somebody to make a decision that feels right. They're very conflicted. And so I try to just hold space for that and just have empathy for it, because sometimes those things are really hard to overcome.
Yeah.
Yeah, it can get very complicated. We are really blessed.
Well,
like I think about that all the time.
You guys are. I mean, you're blessed that you have each other, and that you both, and I'm sure, I'm sure you have your days, but yes, that you can approach this together in a cohesive way. Because I mean, I've had families where the siblings just, it's the opposite, and it's just so hard. And to have that stress along with your aging or sick parent or loved one, and you're in conflict over what to do, or you don't have a relationship with the other person who also needs to be involved in making decisions. But that's part of what I love about my job, is just kind of bearing witness to some of that and trying to see if I can help, or at least just understand, be kind of an empathetic person that can help guide families through that. I mean, sometimes we're just not going to fix those things, or I'll never understand because it's too deep and there's too many layers, but just at least trying to be compassionate for it.
Have you ever had to yell at a family and go, "Get your shit together"?
I've wanted to, but I never have. No. Okay. I mean, sometimes I've had to do a little tough love with people, but again, it depends on the relationship I have with that family and how long I've known them, and what their level of trust is with me. Yeah. That I think I try to always be honest with people, but some people are just not able to receive that. And but I still, do it in the best way I can. But I mean, sure, there have been times where there's been conflict between me or the healthcare team in a family, and I try to get to a place of just assuming they have the best intentions and understanding this is hard, this is stressful. People have so much going on in their lives that I will never begin to know. So I really I try to approach each family with assuming they have the best intentions, that they are a good person that wants to do the right thing, that loves their parent or whoever very much, but is having a hard time. So if I can find that empathy, even for people that are really like struggling or kind of acting out, that just helps me navigate the situation better. There are times where families just are not able to kind of see things the way I see it. And sometimes we just have to like sort of agree to disagree, but I try to never make anybody feel alone or abandoned. I try to still say like, I'm here. Sometimes people need to hear it from somebody else too. Somebody with, a man with gray hair. Sometimes they need to hear it from that.
Yeah.
But most of the time though, I think that we're able to get to a place of kind of understanding and get through some of those barriers. Sometimes when people are really having a hard time, or they're kind of generating a lot of conflict, what I take away from that is that they are struggling with something that is like much deeper than I'll ever understand. Yeah.
That is a really great way to look at it.
Yeah.
That is, and that's a really great message, because I think sometimes people see providers as just like one-sided. Like, you don't care about us. You don't have feelings. You're just like a cog.
You just want our insurance money.
Yes. So I think it's important for people to hear that, like, no, we care about you. We do want the best for you.
Yeah.
Like, we take time for you, even if it's like busy and stressed. Like, yes. And this is why you need to build a relationship with your provider.
I think if I could put a message out there about that too, I would say that, yes, the vast majority of providers, whether that's PCPs, geriatricians, anybody, we really do care. We really want to be there for you, help, understand the situation.
Can you talk about the difference between hospice and palliative? Because there's lots of folks that don't know the distinction.
Hospice is a really great resource for people that are in the later stages of the dementia journey or any chronic illness. There are certain criteria that a person has to qualify for that, but I am in favor of getting hospice on earlier than later so a person can benefit from some of that extra help and support. That's a really great team that can wrap services around a person as they approach the later stages of a disease and through the end of life. Sometimes a hospice is a scary word for people and they think that means we're at the end, but really I have patients that live longer with hospice than without because they're just getting more support and care. So
can you talk a little bit more about that? About why that's, important and what services you're talking about that hospice can offer?
Sure. So hospice is meant for anybody who we think might be within 6 months of end of life, but nobody has a crystal ball to know that. We make our best guess based on certain criteria that a person might be meeting on paper, but I have many patients that have been living on hospice for years. So with hospice, usually it's a team. It is a team of services. It usually comes to the person wherever they are. So wherever home is, whether that's in the community or in some kind of senior living community or, assisted living, skilled nursing, wherever that person might be. And they get a really wonderful team of a nurse, extra aid visits, social work, medications, equipment, a lot of things that can really help take care of that person and things that you don't really get with any other insurance covered service. So what you don't get with hospice is 24-hour care, unfortunately. And I know that's what a lot of people really need that, but it's still extra eyes and hands on your loved one and also access to extra support, especially overnight. If somebody is at home and they have a symptom or a change in their condition overnight, you have a person you can call that will come to the house if needed, a nurse, if they can't talk you through the situation over the phone. So that is a really super helpful resource to help families feel less alone. There's also some other benefits of hospice, including respite. So for people living at home, and if a family needs to go away for a couple of days, go out of town or take a little vacation, that person can actually have some extra assistance or even go into a skilled nursing facility type setting for a couple of days, and hospice will cover that. So that's a really great benefit. With hospice, we're really focused on comfort and quality of life. So we don't use the hospital with hospice, but really the hospital, as we're talking about, is not usually a safe or helpful place for somebody, especially in an advanced stages of an illness. So they really do better in their own environment with bringing the care to them. So palliative care is also kind of more of a philosophy, I would say, of we are going to make sure that this person has the best quality of life possible and has their symptoms managed. And to me, we're all doing palliative care kind of all the time. Like palliative care is just good medicine. As far as accessing services within palliative care, I know at AHN and as well as UPMC and other health systems here in the region, we have palliative care physicians and advanced practice providers that will do visits with patients to kind of just walk along with them in that journey, make sure that symptoms are being managed. Maybe that involves prescribing medications or just kind of working with caregivers, working with the person on any kind of emotional distress. And this is for people with life-limiting illnesses. Hospice is different because hospice is really a structured set of supportive services. We don't really have that yet in palliative care. I mean, palliative care, again, is more of like a philosophy. You can get connected with a palliative care practitioner, but we don't really have kind of this type of set of palliative care services that will actually go to a person and provide nursing and social work and all of these things outside of hospice, if that makes sense.
Yeah.
So palliative care is just a really great space to be in for anybody who's dealing with a life-limiting illness, and you can get connected with a practitioner that will be part of your care team in that. But hospice is a really comprehensive set of services so both are really important. A good primary care doc should also be doing palliative care type, medicine and philosophy in just the everyday care of a person with a life-limiting illness. It's an approach of incorporating what matters most to this person into their care. But it's hard, like I said, in the limitations of just medicine, of some PCPs only having 15-minute visits and that type of thing. We kind of do need this whole team. We need the village. And so palliative care practitioners can be a great part of that village.
That was a great explanation.
Yeah, that was a good one.
Also, not enough of them exist. So also, a very sort of limited group of practitioners that unfortunately we don't have enough access to, but that is also something that I know we're working to change. And I think that there are probably more people that go into palliative medicines, especially than geriatrics. So hopefully this is all changing, and I know palliative care has really grown in the last 10 to 20 years. So.
Wow.
Can people self-refer to hospice? Or do they need their doctor?
They need a doctor's order for hospice. So people can definitely reach out to hospice organizations, educate themselves, set up a meeting. To officially become enrolled in hospice, you do need a doctor's order. But if there is a person who has decided that is a path they want to go, or for themselves or their loved ones, they should absolutely advocate for that. And there should not be a barrier to getting that order, especially as long as the person sort of, meets those criteria and is eligible for those services. How do you all feel about hospice now that you're living it?
So it's unfortunately not our first rodeo with hospice, and they were wonderful.
Yeah, they were wonderful.
Like just having that extra set of eyes, that extra person to say, okay, well, now we think this has happened, to give kind of an advanced, I'm going to say warning, because it's not
proactive.
like bad. Proactive, right? About, this is what we're looking for, approach in an easier setting instead of like necessarily the hospital.
Yeah. And we had the same intake coordinator that we had for our last hospice go around, which was strangely comforting.
Yeah.
Like it was familiar, and only like a kind of sad way. Yeah, and they also have a clergy, and lots of these facilities, their religious services are Catholic, and our father isn't Catholic, and this clergy person isn't Catholic. So like it works out for us. Just because my dad's not familiar with Catholicism, he doesn't go to those services, even though like they are open to everyone. So I think it's more comforting. And she called me so I could give her some info about him. She thought that we didn't know that he had dementia, which I thought was hilarious.
She thought we didn't know?
I think so. She said, he has a little bit of memory loss. I was like, he has a lot.
So let's just be clear. We are really good kids. We take really good care of our parents and anybody else that we love. I don't know why the world seems to keep thinking we're these terrible trash kids.
We were at the hospital with Lloyd, and they were like, I was just called to tell you that your dad's getting admitted to the hospital. I'm like, I know, I'm here.
You would be shocked, though, that is not the case a lot of times. So
I'm just like, we're sitting here. Do you want to talk to the doctor? Because he's right here with us.
Yeah.
Yeah. But I think so far, it's a good transition. For me personally, telling others was like the hardest part.
yeah, it's such a strong word.
Yeah,
People have strong reactions to it.
Yes.
because they
Yeah.
don't understand.
Right.
They don't understand. When you don't see him day to day and when you don't understand, like even people that do see him, like that, there's still like a disconnect.
Yeah. Well, and people associate it with giving up. There's still that stigma.
Yes.
But I tell people and families that it's actually the most loving decision you can make
Yeah.
is to get that extra care.
Yeah. Because we brought it up with you before. And I'm like, as soon as he can get in,
Yeah.
let us know.
Like it's a special club.
Yeah. I'm like, 'cause-
Now, dementia can be tricky because sometimes a person actually has to be really sick to qualify. And so finding that sweet spot where they're not so sick that they're not going to get to benefit from the services for as long as we would hope. But sometimes when we refer a little too early, then hospice has to follow certain guidelines and they have to kind of show that a person really is eligible over time. So sometimes I have issues actually where my patients will be discharged from hospice because they're too stable for too long. And then that's actually a really hard transition sometimes because people have really gotten used to having that extra support and they have gotten to know that team. And then suddenly it's kind of like ripped away. So there's still some tricky stuff that we have to navigate sometimes, especially in dementia care with hospice. But overwhelmingly, it's a beneficial thing, at the right time for the right person and family. And I'm an advocate for that.
Same.
I think that's what makes caregiving so tricky is all of those unknowns and how the unknowns can happen so quickly.
Yes.
And then you might be good and then we're real bad and then just a little good and
We start with like just walking down the stairs and then we're running down the stairs and then we're walking down the stairs.
It's a roller
Then we
coaster.
might be tumbling down the
Yes.
stairs.
It's a roller coaster and things can change very quickly. And sometimes people are just not prepared.
Thank you for listening to another episode of Where's the Adult? And that's it for Pitt.